Okay, good morning. It's great to be back. Just a few comments about the last series of questions. Maybe it was a little bit of a loaded question. Okay, talking about one isolated aspect of the Roux-en-Y. My personal recommendation, since I have the podium here, is to close the defects, folks. There is a randomized controlled trial out of Sweden clearly showing that if you close the defect, you lower the risk of small bowel obstruction, and it is a problem. It's rare, but Mitch is right. It is a problem that can be very, very devastating. So, let's talk about portal vein thrombosis, which is an emerging problem. How many in the audience have encountered a portal vein thrombosis? Okay, almost all of us, right? If you do enough of these, you're going to see these. And if you just look back, maybe 10 years ago, we didn't talk about this problem, right? So what's happened? So these are my disclosures. I don't think any of these are relevant to my talk today. What is relevant is a new textbook myself and colleagues Tom Mogula and Tammy Fouts have just published. This came out a few months ago. It's a very comprehensive book focusing just on complications of bariatric surgery. Very comprehensive, covers all the different procedures and some of the more esoteric complications such as portal vein thrombosis, rhabdomyolysis, all these unusual things that rarely occur when they do. Devastating. This focuses on prevention. It's available on Amazon and also Oxford Press. Okay, another brief commercial. This is the MISS meeting I put on for 18 years. Many of the faculty, including even Mitch, has actually gone to this and spoken at the meeting. Focuses on not only bariatric surgery, but other areas of minimally invasive surgery, hernia, colon, foregut. Great venue in Las Vegas, February 25 to 28. So if you can make it, love to have you there. Another quick commercial. Cleveland Clinic, we have once a month an international broadcast on the internet. Anybody can participate. It's the first Friday of each month. It's called Innovations in Surgery. We have some 30 different academic centers throughout the world participate. But anybody from your own laptop can participate. And we usually talk about very cutting edge topics. You can see Dr. Rosenthal. It's like he's yawning, falling asleep there in one of the sessions. But here's take a photograph if you want, and it shows you the URL and how to access the conference. And finally, some people have asked, can you come visit Cleveland Clinic? We have programs where you can come visit us and observe what we're doing. If you have more interest in this, please feel free to email me at the email address below. Okay, so we all know that these are the four main common operations, and this unusual problem, portal vein thrombosis, has been reported for each and every one of these procedures, but it's looking like that the sleeve gastrectomy may be the more common of these procedures. We'll talk a little bit more about that in just a moment in terms of portal vein thrombosis. This is what it looks like. This is a nice review article by Salman Al-Sabah from Kuwait and his colleagues. He reviewed 10 cases, and here's some CT images. This is a coronal view showing the effects of portal vein thrombosis resulting in infarction of the liver. In fact, the left branch of the portal vein causing segment 4A infarction. Here's another coronal view here showing portal vein thrombosis, complete occlusion here. This one down here is an axial view showing occlusion of the portal vein. And then finally, this image, the far lower right, shows cavernous transformation. This is several months after treatment of a portal vein thrombosis. So this is the most common way to diagnose the problem, and usually patients will present with abdominal pain. You get a CAT scan, and lo and behold, surprise, you see portal vein thrombosis. Reviewed several papers. This is the most current and actually the most comprehensive study published in Sword just a few months ago, and they reviewed the world's literature on this topic. They actually reviewed several hundred papers and came down to about 41 articles that had enough information to really compile into some type of systematic review. And within these 41 papers, they were able to identify 110 cases of portal vein thrombosis. And this involved not just sleeve gastrectomy, but all bariatric procedures. And they pointed out, in terms of the literature reports, this is a relatively recent phenomenon in terms of reporting, although the reports going back to 2002, they're very rare. But you can see a gradual increase in the publications and certainly the number of patients reported per year with portal vein thrombosis. And this seems to be parallel, of course, to the rise of sleeve gastrectomy. It's quite interesting. So here's sort of the summary of what came out of this paper of 110 patients. It turns out the incidence appears to be about 0.4%, so about 4 per 1,000. If you're a busy surgeon, you're going to see this every couple of years or so. And they pointed out potential risk factors. It's very difficult in these studies to tease away whether these are actually key etiologic factors or just associations, but a little more than a third of the patients were on oral contraceptives, which is a known agent to produce deep venous thrombosis. More than half had prior surgery. A fair number were smoking. 47%, so nearly half, had some type of hypercoagulable state. And of the 110 cases reported, a large majority, nearly 80%, came after sleeve gastrectomy. Interestingly, we often think of pneumoperitoneum, or increased pneumoperitoneum pressures above 15 millimeters of mercury as a potential etiologic factor. This was reported in just 6% of the cases. And this may be because the surgeons didn't necessarily report that the pressure was higher during the case or not. So be careful how you interpret that. And most of these, to no surprise, occurred within the first month of the operation. And many of these patients had actually been discharged from the hospital and presented back either in the hospital or clinic with a variety of symptoms, which I'll talk about in just a minute. To no surprise, the majority of these occurred in the portal vein, 42%, 35% occurred in the superior mesenteric vein, and 21% occurred in the splenic vein. And this pie chart shows you the myriad number of symptoms that may be presenting factors or presenting symptoms. By far the most common was abdominal pain, followed by nausea and vomiting, and then a variety of other symptoms, including malaise, dysphagia, constipation. A fair number had fever, tachycardia, a few had GI bleeding, leukocytosis, anemia. Some abnormal laboratory values are shown here: elevated liver enzymes, lactate, amylase, C-reactive protein, elevated D-dimer. Some of these folks presented with a degree of metabolic acidosis, thrombocytopenia, and splenomegaly. In terms of severity, the majority of these at presentation actually had evidence of a complete occlusion of one of these major portal vessels, whereas 30% had partial occlusion. Now the etiology is somewhat circumstantial here. They did identify about 3% of the cases were actually clearly iatrogenic, where the surgeon stapled the portal vein. A number of these, it appears that a hypercoagulable state was a major etiologic factor. Most commonly, prothrombin 20 to 10 mutation occurred in 10%. Protein C deficiency 10%, and protein S deficiency, 8% of the cases. So these are things to look for in your patients that might predispose. And this is a more detailed assessment of all the different hypercoagulable states and the relative incidence in this series of 110 patients. In terms of treatment, the vast majority of these folks received anticoagulation, either unfractionated heparin, some use vitamin K antagonists, some use low molecular weight heparin, and interestingly, some required surgery. About 20%, so 1 in 5, required bowel resection due to venous congestion and venous-related ischemia of the bowel. A couple required splenectomy, and actually one patient in this area required a liver transplant due to liver failure. The overall outcome in terms of length of stay was quite variable, from 5 days to anywhere to 57 days, and quite a few of these folks ended up in the intensive care unit. Overall morbidity rate was 8.2%, and among the morbidity, a number of these folks developed some type of abdominal sepsis. Overall mortality, certainly not trivial, 3.6%. Now, there's a number of risk calculators out there on the App Store. I just want to share with you one that we created. Actually, my colleague Aaliyah Minion at Cleveland Clinic had created. It has a number of different types of calculators. I showed you yesterday one that helps you calculate the probability of remission after type 2 diabetes and helps you select the procedure. We also have a VTE risk assessment calculator that you can plug in some key risk factors, such as the patient's age, gender, history of hypercoagulable state, oral contraceptives, so forth, to come up with a relative risk of developing any type of VTE, including portal thrombosis. So something you might want to consider, because obviously prevention is the key here, as opposed to trying to manage these folks post-event. So in conclusion, portal vein thrombosis, a relatively newly recognized phenomenon, although this is probably has occurred since the dawning ages of bariatric surgery, but probably went underreported. It is rare, but 0.4% is significant, and every surgeon will eventually have one if you do have cases, and it's potentially deadly and associated with high degree of morbidity. Prevention is the key, as I mentioned, identifying the risk factors up front, getting patients off cigarette smoking, stopping oral contraceptives, identifying those with a history of hypercoagulable state, and providing aggressive prophylaxis are key. When the event does occur, obviously one key is early diagnosis and recognition of some of these vague symptoms, and prompt assessment, typically with an abdominal CT scan, and then prompt institution of anticoagulation therapy. The duration of therapy is controversial in terms of the length. Most surgeons will use at least 6 months of therapy. Some will extend this beyond 6 months. And finally, there's still very little known about the actual pathophysiology of this condition, particularly as it relates to sleeve gastrectomy. It's been hypothesized that by dividing the short gastric vessels, we're altering portal vein blood circulation and probably creating a state of stasis, which might promote portal vein thrombosis, but this is mostly speculation at this time and has not been subjected to rigorous study in a human or animal model. So that concludes my presentation, but something that all of us should keep in mind, this potential complication, especially if you do a lot of sleeve gastrectomies in your practice. Thank you very much for your attention.